Hello and welcome to In Service of Health, brought to you by the Public Health Accreditation Board. This is the podcast that brings healthcare and public health leaders together to inspire new thinking for healthier populations. In this episode, I was pleased to sit down with Dr. Scott Harris, the State Health Officer for the state of Alabama. Dr. Harris is a seasoned professional across the public health and healthcare sectors and has led several important efforts to improve health outcomes and address disparities. We reflected on a breadth of issues ranging from how to build trust in public health, how to advance initiatives in a political environment, and how to tackle the challenges we see in rural communities. I hope you enjoy the episode. Dr. Harris, thank you so much for joining us on the podcast today.
Thank you very much for having me. It's a real pleasure to join you.
It is. So let's just jump right in, if you don't mind. You have had such an amazing career. Tell us a little bit about what motivates you to do this work.
Wow, I've been in this role for a little over 8 years actually, and I think the reasons I enjoy it won't really be a surprise to most of your listeners. I really love public health because it's an opportunity to help your community. It's an opportunity to do good. This is the best job I've ever had. I've been through some other jobs. I was employed by a health system as a physician for a while. I was a sort of a independent private practice doc for a while. I've had a couple of other administrative roles. But when I came to public health, I really felt like I met a lot of people who shared the same values I have, and public health is just an opportunity to help others. It's an opportunity to serve. I have to say, I really enjoyed being a private practice physician before. I was an HIV doc for about 20 years. That was really rewarding work. I really, developed great relationships with patients, with families, and that's terrific. But coming to this position now, I feel like I have an opportunity to take care of populations instead of just one at a time. And I suspect, you feel that way yourself, or a lot of people in public health feel that way. But it's just the best job I've ever had.
That certainly resonates with me as well. Thank you for that. Tell our listeners, why is public health important to you? And quite frankly, why should it be important to society?
Yeah, public health addresses so many things that our society otherwise tends to overlook. It addresses caring for a lot of people that get overlooked in our society. It really addresses a lot of areas strictly in the area of health that our healthcare system overlooks. Our country has, more or less a for-profit healthcare system. There are a lot of good aspects to that, I guess. But essentially, it means that not everybody has the ability to get the health care that they need. It's really astounding sometimes how much we've all become at ease with that in our country. If you live in an area that has, lots of healthcare facilities, and if you're affluent enough, or if you're lucky enough to have a job that covers, majority of your healthcare expenses, then you really can get the best healthcare in the world in this country, or thereabouts. But that doesn't really apply to everybody. There are many Americans who, through no fault of their own, just are never going to be in that situation. And so that's what we attempt to do in public health. I say attempt because we're never probably ever going to really get there. Public health is it's a work in progress, and we're here to meet unmet needs, and those needs change over time. There was a time when, public health became a thing, 150 years ago, and people were concerned about, having clean water to drink and, killing mosquitoes. And that was kind of what public health was.
Yeah.
And then over time, we focused on immunizations, and over time we focused on food safety. And now we're dealing with, seat belts and firearm safety and things that we probably couldn't have imagined, all that long ago. So public health evolves to take care of people, and there are always going to be people who have those needs that are not being met. I think most people don't appreciate our profession because we operate in the background so much. We're kind of the silent guardians of health, and you can go out to eat and not worry about your food's being safe, and you can turn on your tap and drink the water without thinking about it, and you can send your kid to school and not worry that they're going to be exposed to some communicable disease. And that's because a lot of people in our profession are working really hard behind the scenes.
Wow, that's such a perfect description of public health, and I appreciate you saying that the silent guardians of health. We evolve over time, and you talked about clean water and killing mosquitoes. Having been a health officer as well, we still do that.
Yeah, yeah, right.
That's still pretty important. I'll tell you, when it's not working well, it is not good for anyone. So
Yeah.
thank you for sharing that description. Let's go back to your career. And similarly, I'm a practicing physician but work in the public health space. And you started your career, as you noted, in infectious diseases. How can you talk to us about how your experience as an IV doc informed your approach to leadership, to leading during a crisis, to leading teams?
Sure. I was attracted to infectious disease for originally, to be honest, because I just had a couple of great mentors when I was a medical student who were in that profession, and I just thought, gee, these are the smartest people I've ever met. I wish I could be like these people. So I ended up in HIV, and it was at the time when HIV was first really exploding in the public consciousness, and when we first started getting the ability to actually treat patients and make a difference in outcomes. And it was a really exciting and interesting time, just purely from an intellectual standpoint, I guess. But I will say over time, that's when I really sort of developed a concept of what nowadays we would call social determinants of health. Nobody knew that phrase at the time,
Yeah.
but when you practice medicine for a while, you realize that not everybody's at risk for everything, and a lot of people are at risk for everything or many things. And so it really gradually began to dawn on me that there were just a lot of really vulnerable people out there. So that sort of brought me into the sphere, I guess, of public health. I actually knew about public health my whole life because my mom was a public health nurse, and I was
Yeah.
a kid who went to the health department after school so I could get a ride home, and was kind of aware of that world. But after I began practicing infectious diseases, I started to collaborate with local health departments and seeing some of their HIV patients or TB patients or STI patients, those sorts of things. And gradually just realized that this was a great place to sort of take, I guess, the skills I developed and try to put them into practice. ID is a great fit, as you might, imagine, for public health, because there's so many communicable disease issues that we deal with, just like, pediatrics and OBGYN or, family medicine are always good fits for public health. But I think I'm really am fortunate that even though I've ended up, in this sort of big bureaucratic organization, managing operations and, finance and HR, I was fortunate enough to have this history of just taking care of patients, just sitting in an exam room, one person at a time, and hearing about what's going on in their life and trying my best to help them. And that's probably the best lesson I could have gotten for this job.
Yeah.
It just reminds you that, for all these, generic population health, impersonal kind of programs, we're really just taking care of people. We're just trying to help people live their best life.
That's right. We're just trying to help people. And I love what you said in the connection to infectious diseases. As you're speaking, I'm thinking, yeah, infectious diseases usually are preventable. It's not about genetics. And there are things, to your point about the social determinants of health, the buzzword, if you will, that we all know now. There are things that are in that environment that are no fault, as you noted, of that individual person, but it's really about those systems and those structures. So thank you for connecting the dots between infectious diseases and the physician and public health. So let's transition a bit. So you also were the president recently of the Association for State and Territorial Health Officials. I've been honored to be a member formerly as a state health officer and now as an alum. And this is the organization, for those who are listening, that represents state and territorial health officials, obviously. But you were there after the pandemic and also as our country has grappled with other urgent public health challenges. Tell us about that work, that role, and what have you seen or heard or learned, I'll say, from your other state health officer colleagues across the country around public health, around public health leadership? That's a lot of questions there, but talk a little bit about that role, some of your work there, and engaging with state and territorial health officials.
Oh yeah. Wow. There's so much we could talk about. As you and I first met through ESTO. You were serving your time in Michigan as state health official, and that was pretty soon after I had gotten this role in Alabama. And if I remember right, I think we met on Meet the Press one time. Like, right, here's
That's
a blue
right.
state. Yeah, here's a blue state, and here's a red state. But
And we're all the same. We're all tackling the same thing, right?
yeah, that's exactly right. Yeah, and in thinking about that in the years since, we were talking to Chuck Todd, what I remember is I think like, networks tend to do, I think they got a blue state and a red state, and maybe that's to have different opinions. But I think people assume there's going to be conflict if such a terribly, political time, and everything was so partisan, and, this, that, and the other. But even when we were talking together, it reminds me of what has happened in my time at ASTO. Those of us who represent public health, we kind of pretty much agree on most things. There's a lot of difference about what's politically possible in your jurisdiction, and there's a lot of things you can't say or can't say depending on your governor and what state you're in. But I think all of us have this fidelity to science, and also this dedication to trying to improve people's lives. And that's really what I have gotten from ASTO. ASTO has been so tremendous for me. The real reservoir of public health knowledge in this country probably doesn't reside with people in my position. The state health officials cycle in and out pretty fast. A lot of them are strictly political appointments. You get that job and you try to make a splash in 2 or 3 years, and then have to go and somebody else comes in there. The people who've been doing public health for decades in this country are either the people who work for us in the state health official space, or they're the people at ASTO. The people at ASTO have tremendous knowledge and experience and a lot of expertise in public health systems and how to get things done, and policy, and what works and what hasn't worked in the past. So this past year, basically 2025, I was really privileged to be in that role as president. And I have to say, I had a lot of great ideas about, how I was going to promote public health all over the country. But we had an election, and the administration changed. Suddenly, the landscape wasn't what we were used to, and we, saw, these funding crises. We saw, CDC going through these unbelievable changes, and people that we have all known for years and years suddenly out of work. And I have to say, I spent a lot of time during that presidency year just focusing on trying to keep the train on the tracks. There aren't a lot of nonpartisan national organizations anymore. I can think, for example, the National Attorney General's Association split into a red one and into a blue one. And that's just one example. I think we really had some risk of red governors and blue governors going, we don't want our health officials in that same organization with those other people. But fortunately, that really never happened. And I think it's a testament to the fact that public health people are just generally always on the same page. They generally have this, have their eye on trying to, promote health and safety of their populations. They generally believe in science, and they're just kind of reasonable people, that can get past these political differences. So what I really learned during that year was just to listen to people that were coming from a political space that was a lot different from mine, and also made me think a lot about how I represented myself and my state's politics and my governor and so on when I'm talking to people that are coming from completely different spaces. And I would say I think ESTA really is stronger than ever. I think everyone who's been through that in that role, we realize that it's almost a trope, but we really have a whole lot more in common than we have differences.
Yeah, I appreciate that. And also there's two things I'm noting there. Is the importance of listening. And just as a leader, quite frankly, as a doctor with public health, the importance of listening is just really so paramount. I'd also say the importance of, at least something I got from ASPO, the importance of connecting with colleagues across the country who are grappling with similar challenges. It may be a little different in every state. There may be slightly different political leanings in various states, but at the end of the day, people are people. The human body is the human body. We're all susceptible to the same infectious diseases, and so we're really all in this together. So, like you said, ASPO, and you got to give a shout out to the Public Health Accreditation Board as well. I mean, these public health organizations, we're nonpartisan, and we're really working to help across the country and beyond. So I appreciate the comments in there. Let's talk a little bit on that. Talk about listening. How do we build or rebuild trust in public health, particularly with public health? As you know, it has become, unfortunately, such a polarizing issue in some spaces.
Yeah, I'm just going to really be honest with you. I'm not sure what the answer is. Although we spent a lot of time thinking about it, just like you have. I know. I do think it's important for people in public health who, like us, who are really agonizing over that question, to pause and remember it's not just us, right? We live at a time when there's just kind of historic levels of mistrust against institutions in general. So it's not only public health, right? You have, big segments of our country who don't trust, politicians, and they don't trust the media, and they don't trust big business, and they don't trust, you name it, their healthcare systems. And then we're also part of that, right? And we're a very visible part of that because we're coming out of the pandemic, and it's easy for people to point to us and say, show how we messed up and did something wrong, and therefore justify the reason they mistrust us. But it's not only us. Again, I don't know the exact answer, but I think I don't think whatever the answer is, it's not complicated. Like it's complex. There's going to be a lot of moving parts, but it's actually straightforward in that you build trust the same way you build trust in any other relationship. You sort of show up and you're honest and you listen to people. You have empathy for other people. You try to have a good heart in terms of helping others and communicating that. You admit when you do something wrong, and you try to fix it. Those are all things that you learn in, your relationship with your friends and family or anything else, right? So we got to figure out how to do that. I think it's easy to oversimplify it and go, well, we just need a different social media campaign to tell people how great we are, and that may be a component of it, but clearly there's a lot more than that. But you almost really have to repair it one person at a time. And I live in a state of 5 million people. That's kind of a small state overall, but I'm never going to reach 5 million people. But we have proxies, right? We have the old trusted messenger that we talk about, and I think that's how we get there. I think we find the people who can communicate for us, who can reach the populations that we can't reach, or reach the populations who aren't interested in hearing from, me, the state health officer. And that's how we get there. But again, it just basically is listening, being empathetic, showing up, admitting that you're wrong, hope for the best.
Thank you, Dr. Ayers. And as you're saying that, it sounds like what I tell my children when I'm trying to teach them basic lessons of being in the world, right? It's like those things go a long way. Empathy, caring, show up, they're gonna do. It's not always about you. You know what I mean? It's those some really basic things that it would be great if we all kind of embody those as we move forward. So thank you for that.
Yeah.
Um, let's switch gears to rural health. Alabama has a large rural population, obviously. We know significant disparities exist between rural and other urban areas, whether it's high rates of uninsured, higher rates of smoking, less access, as you noted earlier, to healthcare services, worse health outcomes across a multitude of diseases and conditions. How do we, or how do you think about the challenges in some of your more rural areas in Alabama?
Yeah, it really can be overwhelming. Our state is around 45% rural, considered to be 45 or so percent rural, depending on how you define it. And in rural areas are where we find, our most disparate health outcomes, our worst health outcomes, whether it's um, cervical cancer rates or infant mortality or cardiovascular disease, you name it. Rural Alabamians are a lot more at risk. And then at the same time, those are the areas that are least served by medical professionals, by facilities like hospitals, and what's causation and what's association. But clearly, that's where, if we're going to make any difference in the overall status of our state, that's where we're going to get our bang for the buck. That's where we really have to concentrate our areas if we're going to improve overall health outcomes. We have a few large population centers in our state, and don't get me wrong, there are underserved people in those more urban areas as well. But generally speaking, in my state, if you live in Birmingham or Huntsville or Mobile or Montgomery, you can get pretty good health care. You have pretty good access to it, even though not every individual person does. But large swaths of our state, you, you can't get health care at any cost. I mean, there's just nowhere to go. There's nowhere to turn. So in our jobs, it's not always easy to figure out which buttons we have to push. What are the options we can actually do to impact that? Um, we can't in public health really help the fact that you know the financing of rural hospitals is just kind of economically unsustainable. There are a lot of reasons for that, and a lot of that involves federal policy. A lot of that involves, policy in our state. Like, for example, we're not a Medicaid expansion state. I have no defense for that. I would say it's been a political decision, and it's, unfortunately, hurt a lot of Alabamians and hurt a lot of rural hospitals and healthcare facilities. But also, that's something that's not quite within our power to, affect, or at least to change here in Alabama. Other people are going to have to do that work. What we can do, or again, touch the things that we can touch. For example, we regulate EMS, emergency medical services, in Alabama. So we do a lot of work trying to keep those systems up and running. It's really challenging because they're a financial loss for most counties. Most of those aren't really making money. Many of them, many counties have a single EMS unit in Alabama, and so, but no hospital. So you get one single, seriously ill person, and then your EMS is, taking them 2 hours away to a hospital, and then you just don't have services in that county for 4 or 5 or 6 hours, period. And that's a common thing. So we've done work of trying to get EMS sort of trained and having the capacity to take care of more things on site. They have closer connections to medical directors who can oversee, more and more complicated interventions, at a local location, whether that's obstetrical care, whether it's trauma care, whether it's certain types of pediatric things that normally wouldn't be addressed in the field. We're trying to figure out ways to safely do that, because they're not, other options in many cases. We do a lot of work towards, like most health departments, in terms of provider recruiting. We have an Office of Rural Health. We manage, these programs to try to place rural physicians and other healthcare providers. it's great work, but the truth is we're never going to solve the problem with that. If you're a high earning, professional, potentially high earning professional and a physician, or any other professional for that matter, rural Alabama is just not attracting those people. Again, no matter how much money you make available to them. So we certainly think that's a component, but it's not gonna solve everything. We're working with facility conversions. We hate to lose a hospital, but sometimes we can, help it convert to a critical access hospital or to a rural emergency hospital. That keeps some services available in those rural communities. Fortunately, um, again, it reminds me of what we talked about a minute ago about trust. It's not just that these rural areas don't have medical care. They don't have a lot of things. They don't have school teachers. They don't have attorneys. They don't have bankers or people in the financial industries. Rural areas are really getting more and more sparsely populated. But the difference between all those other professions in medical care is that every person needs medical care at some point, every one of them. So eventually our governing bodies are going to have to reach a conclusion that that's just an essential service and it's got to be provided for. Market forces aren't fixing that problem. The reason we do what we do in public health is there's no financial model for giving free health care to poor people, which is a lot of what we end up trying to do. That's got to be a role that government plays, and we just need to find more support for that.
Yeah. Thank you for your leadership in that space. And you touched on this a little bit, but can you give us some more examples or ideas around how public health and healthcare in particular can do more or work better together, even if you could have lead into something like infant mortality or other specific health challenges? What have you seen work in that space?
Yeah, infant mortality, like most people in public health, I've spent a lot of time with really great professionals who are working on infant mortality problems. Alabama has seen some real improvements in our state. We're nowhere near where we would like to be. Our country as a whole, as you know, is not really where it ought to be. But in Alabama, infant mortality, unfortunately, the bulk of our disparity is driven by deaths among Black infants. That is, just an unfortunate fact. We've made these gradual improvements in infant mortality for decades, and in the past 3 years, we've had two of the three lowest infant mortality rates we've ever had. So we're trending the right way. And yet, the gap between mortality rates among white infants and Black infants hasn't changed that much. Black babies are more than twice as likely to not survive that first year of life as compared with white babies. So, that's not acceptable to us, and we have a lot to do. Um, Infant mortality, as you well know, is such a complicated problem, and there's so many different facets to it, and there's so many ways that it's affected by local providers and insurance rates and your pre-morbid condition of women of childbearing age and or morbidity in women of childbearing age, and just government policy, health policy overall, and transportation needs. I mean, you can just go on and on and on. So really our approach has been to try to get out of our silo and try to operate with lots of other people that are doing the same kind of work, but maybe touching it in a different way. We put together a big infant mortality task force about 7 years ago that really just brought in all the government agencies that had various aspects of that work, as well as some of our big stakeholders, some of our hospital association, big healthcare system, people like that. And we have gradually started trying to expand from one county to the next, throwing every single thing against the wall that we think is going to stick. So whether it's home visitation programs for pregnant women or recently delivered moms, whether it's mental health resources for getting postpartum moms recognizing that they may have mental health issues and trying to get them to care right away, whether it's nutrition programs to try to see them prenatally, whether it's these well woman programs that financed through CDC that looking at cardiovascular risk and diabetes risk in women of childbearing age. We actually had a kind of a unique opportunity here because our agency, our public health agency in Alabama, manages the Children's Health Insurance Program, CHIP. Um, as far as I know, we're the only state health department that actually has CHIP. It tends to, be a Medicaid or be a standalone agency. But through CHIP, we were able to actually add an option that's called unborn child coverage, and this was really sort of an option that got created, over 20 years ago in a Republican administration. But it has been used to reach a lot of women that otherwise can't get taken care of by Medicaid. Um, Essentially, if a woman is eligible, if a woman's in the CHIP income range, when she becomes pregnant, the policy treats that unborn child as eligible for CHIP instantly. And so we can give this mom a insurance card that effectively, it's supposed to be for the child, but effectively gives her prenatal care. And we're able to get a few thousand women a year prenatal care that otherwise would not have any at all. It also allows them to show up and get their full hospital stay paid instead of emergency Medicaid delivery or not being able to pay at all. It reimburses hospitals and healthcare providers, and so we're very proud of that fact. And we had to really work to sell that a little bit. And people on one side of the aisle, were fine with us just expanding care no matter what. But people on the other side of the aisle really like the sort of economic savings that we could realize by giving people prenatal care and trying to prevent birth outcomes that would be real expensive to somebody on a program like this. So that's been a big step for us. But overall, it's just there are all these threads out there that you just kind of have to weave together because we're all accessing just a little bit of that problem.
Absolutely. And these challenges are so complex and multifactorial, as you noted. And, dare I say, I think our maternal morbidity, mortality, disparities, infant mortality disparities is just one of the tragedies of the U.S. healthcare system, quite frankly, so preventable, as you noted. But I also love how you spoke about, you have what you have a political situation, but you can still think outside the box and understand where different players are coming from. And quite frankly, what's also underneath what you just said is oftentimes better health outcomes are also going to save money. And so, although that's not why we do this work in public health, that is often a fact, is prevention is cheaper. Again, very, very common, right? So,
100%.
yeah, so thank you for sharing that. As we think about the national landscape, what do you think? Maybe there's one thing that you think is the biggest opportunity for advancing public health in the United States, given where we are today.
This is kind of an inelegant response, but I think right now, I think we're always looking for how do we keep our work solvent and still able to do the work that we want to do. And right now, funding opportunities are coming from one particular bent. And so we are looking really closely at what we're hearing from HHS about making America healthy, and whether that's nutrition related things, food safety, those types of, physical activity, thinking about the diseases of, bad nutrition and sedentary lifestyles. Those are things that, the current administration is really willing to fund, I think. And so we're trying to really get hard into that space. Now, there's some other things in that administration that we're really fighting a rear guard action on and trying to prevent this attack on vaccines. It's just totally unprecedented in my whole lifetime. There's a lot of issues that, as all public health people are concerned about. But even though sometimes it feels like you're capitulating a little bit to say this, it's pretty clear. No matter what political party people are in, they kind of mostly want the same thing. They kind of may be going at it what we would say the wrong way, or different ways. But most people just want to be healthy. They want their kids to be safe and healthy. They don't like being sick. Nobody wants to be in the hospital. And so I think if you start with that in mind, you can look for opportunities. And for those of us that are, atop of these agencies, that really means identifying funding. I mean, the federal funding is the lifeblood of state health departments, state and territorial health departments. So there is a lot to work with there. Is it worth the damage we're seeing to our vaccination programs? I guess time will tell on that.
Yeah, well, thank you for that. And find the common thread that we're all kind of interested in. We're all interested in being healthy and living good lives and supporting our children. That's that. So, well, thank you so much, Dr. Ramirez. Thank you for joining us. Such an enlightening conversation. Thank you for your leadership and your empathy and your listening, quite frankly. Certainly are just a national treasure. And thank you for the work you've done for public health throughout your community.
Oh, you're very kind. It's wonderful to be here. It's great to see you and speak with you. I'm really honored that you would have me, and just really enjoyed it today.
Absolutely.